Robotic prostatectomy is a procedure in which we remove the prostate, typically for cancer. If you're diagnosed with prostate cancer, high-grade cancer such as Gleason score 6, 7, 8, and 9 are candidates for a surgery. A robotic prostatectomy, there are two types of robotic prostatectomy. There's a simple prostatectomy, which is considered a non-cancerous procedure where you only enucleate the prostate and leaving the rest of the prostate intact. In a radical prostatectomy, we are removing not only the prostate, but also the seminal vesicles and the vas deferens that are connected or very much connected to the prostate. So those are removed for cancer purposes. The prostate, as you know, is an organ that's located between the bladder and the urethra. We urinate through the prostate, and the prostate is also a sexual organ. The prostate allows us to ejaculate because the ejaculatory duct is within the prostate. So in removing the prostate, you will hopefully be cured of your cancer, but as a side effect of that, you would also lose your ability to ejaculate, meaning you can still have orgasms, still have climax, but the product of the climax or orgasm will no longer be there, meaning you won't be producing any semen, or would you be ejaculating. One of the things you still have preserved in a radical prostatectomy is what we call the bulbourethral gland, or the Cowper's gland. So you still have that clear white fluid that comes out to lubricate the inner portion of the urethra with sexual arousal. So a radical prostatectomy is done robotically. Typically nowadays in the United States, the vast majority of prostatectomies are done robotically. There are still a few people are still performing what we call open or traditional prostatectomy. There are two types of robotic prostatectomies. One is to go into the abdomen, what we call an intra-abdominal or transperitoneal approach. The other one is the retroperitoneal or non-intraperitoneal or retroperitoneal approach. So the difference between the two is that in a intra-abdominal prostatectomy, you're actually going into the cavity of the abdomen where the vital organs such as liver, a spleen, and your colon and your intestines are located. In doing that procedure, there are risk to injury to those intra-abdominal organs as opposed to the retroperitoneal approach. The retroperitoneal approach, we go below that cavity. So within our abdomen, there's a sac that holds all of our vital organs, such as the liver and the intestine. That's called the peritoneum. The bladder and the prostate are located below that or outside of that space. So in taking out the prostate, the vast majority of robotic surgeons in the United States are performing it in a transperitoneal approach. I, however, have been doing almost all of my prostate in what we call a retroperitoneal approach, where we go below that sac and not go into that abdomen. Thus, it eliminates the risk of injuries to those vital organs. So in a retroperitoneal approach, I go below the belly button, go into the space, what we call the retroperitoneal or below the peritoneum, locate the prostate, and then remove the prostate by separating it from the bladder and then separating it from the urethra, taking out the prostate, the seminal vesicles, and the vas deferens. Once that's removed, then I would then reconnect the bladder to the urethra using a suture that will be a continuous suture that ties the two tubes together and reconnect it. In putting it together, once it's put together, I then put a catheter in. The catheter will allow the bladder to drain urine. If we didn't have a catheter right after surgery, because of the swelling, most patients will not be able to urinate. And studies have shown that if you don't leave a catheter in, most patients will go into what's called urinary retention. And thus, eventually, in a few hours, when they can't urinate, we have to put a catheter in. The other reason why you put the catheter in is because you've just recently reconnected the bladder to the urethra. So you have to allow it some time, usually about a week, for the connection or the anastomosis to heal up. Thus, When you have a radical prostatectomy, the catheter will stay in for about a week or so. Some people will need it in longer than a week. People have bigger prostates or have had prostates that's had previous surgery or a wider bladder neck, or people who heal up more slowly. People on certain type of medications that would make them less likely to heal up faster, people on steroids or chronic steroids. So we also have patients who are chronic diabetics, and those patients sometimes would take a little longer to heal up. So we may have to leave the catheter in a little longer. But on average, most patients will have their prostate surgery and then have the catheter stay in for about 7 to 14 days before we remove the catheter. The surgery can be done either robotically multi-port or robotically single port. In a single port, there's usually 1 or 2 incisions. In a multi-port, there's usually about 5 incisions, 4 for the robot and 1 for the assist. The 5 incisions and all the incisions are usually below the belly button, and all those incisions are closed internally and buried stitches that are dissolvable. So there are no stitches on the outside. And then the skin would then be closed with a skin glue. The skin glue is impervious to water, so patients who have a radical prostatectomy can pretty much take a shower right away. They don't have to worry about any type of dressing changes, anything to worry about, because the glue will stay on for about 3 to 4 weeks, and it will eventually fall off by itself. Just as when your skin sloughs off, it will slough off also. So that's a radical prostatectomy, what to expect after the procedure. During the surgery, my surgery usually takes about 2 hours, plus or minus a few minutes, maybe sometimes less than 2 hours, an hour, 45 minutes, sometimes a little bit more than 2 hours, maybe 2.5 hours. Blood loss for my patients are usually less than 100 to 200 milliliters of blood, so not enough to really worry about blood transfusion. The vast majority of my patients do not require blood transfusions or have to worry about excessive blood loss with the radical prostatectomy. In addition, once the catheter is out and you return for us for a postoperative check-in, and we make sure that you're doing well, what we like for you to be able to do is have minimal pain. There shouldn't be any more bleeding or blood in the urine, so the hematuria has resolved. That usually resolves within first couple of days after surgery. Most patients are with no pain or minimal pain. Typically, you do have pain for the first maybe day or two, and the level of pain is anywhere from anyone can be from a level 1 up to a level 5 out of 10 on this pain scale of 1 to 10. Some patients are able to take no pain medication at all. Some patients only require some Tylenol or Motrin or ibuprofen, and some patients will need a stronger medicine like a narcotic, such as oxycodone or hydrocodone or tramadol. I typically send all my patients home with an antibiotic and some pain medication, which the patient may or may not need to pick up. If they don't have pain, they don't need to pick it up. If they want to pick it up and have it in their medicine cabinet but never use it, that's perfectly fine. And then there are some patients who have pain and may need to take it for several days. So in summary, I think that's all I have to say about a radical prostatectomy. Let me talk to you about why I prefer to do what we call a retroperitoneal approach. In a normal or routine multi-port abdominal or transperitoneal approach, for the surgeon to be able to do the surgery, the abdomen has to be insufflated, or it has to be blown up like a balloon to give it space. And most of the time when you blow up the abdomen, you have to keep it at a certain pressure, typically anywhere from 10 to 15 millimeters of mercury of pressure with carbon dioxide. Now, that extended amount of insufflation of the abdomen causes the patients to have, a feeling of bloating. It may also slow down the intestines, and it can also cause the kidney function to slow down, especially if the pressure is very high or the intra-abdominal pressure is high. In addition to that, when a patient is getting a transperitoneal approach, they would then have to be put on their head, what we call a Trendelenburg. And the degree of Trendelenburg is quite steep so that the intestine and the bowel will move away from the pelvis so that the surgeon can get to the bladder and the prostate. And that's the disadvantages of the transperitoneal approach, because then you're putting the patient in an abnormal physiological state, meaning the abdomen's blown up. You compromise the diaphragm and the breathing. So the breathing, as managed by the anesthesiologist, is a little harder, as you can imagine. And then secondly, you're on your head. And if you're on your head for 2 to 3 to 4 hours, that causes a lot of changes to your intracranial pressure, your eye pressure, and overall, it's just not very good for the patient. So the advantage of a retroperitoneal approach is that I do not have to tilt the patient, because I don't have to worry about the intestines being in the way, because it's not even in part of the space that we're working in. So without the Trendelenburg, there'll be less intra-abdominal pressure and less pressure on the brain and the cranium, the eyes. And that's the other good thing about this, is that in a retroperitoneal approach, I am not insufflating the abdomen. So the only area that's going to be insufflated is the area below the abdomen. So the intestines, the kidneys, the aorta, and the inferior vena cava, or IVC, are not compromised by the pressure. So that's why I approach the radical prostatectomy using what we call a retroperitoneal approach. I could do it either with the single port or the multi-port. And so I think that's a great advantage for patients. The patients wake up feeling better. It's better management for the patient during the surgery. So there's less trauma, less work for the anesthesiologist to overcome all the physiological changes from the increased intra-abdominal pressure, as well as the Trendelenburg, where the patient's on their head for about 2 to 4 hours, depending on the surgeon and the type of surgery. In addition, because I'm in the retroperitoneal space, there's no intestines and vital organs that can inadvertently injure. In addition, when patients have had previous abdominal surgery, there may be scar tissue or adhesions, all of which I don't have to worry about if I go retroperitoneal. And then finally, if you have a virgin belly, quote unquote virgin belly, meaning you've never had intra-abdominal surgeries, my approach, which is a retroperitoneal approach for a prostate, will also eliminate any chances or risk of future adhesions that can form from the surgery, because we're not going into the abdomen. So things that a retroperitoneal approach will be advantageous for us to eliminate any future risk of developing what we call small bowel obstruction from adhesions or kinking of the bowel because of previous surgeries in the abdomen. So we're going to go to the next one. I'm going to talk about single port versus multi-port. Here in Syracuse, both hospitals, Krause and St. Joe's Hospital, have the single port Da Vinci surgical system. I utilize this for a vast majority of my surgeries, including the radical prostatectomy. I prefer the single port because it has less incision, so less pain, less cosmetic issues with 1 or 2 incision as opposed to 5 or 6 incision. And at other hospitals that do not have the do not have the single port, I can utilize the multi-port and still perform the surgery in a retroperitoneal approach. Is there a big difference between the multi-port and the single port? Studies have shown that people who have had single port surgeries have less pain, a better cosmesis because it's less incision, and possibly a quicker recovery. But at the end of the comparison, if you look at, if you take away the immediate recovery phase and also the cosmetic look of having 1 or 2 incision versus 5 or 6 incision, there's not a big difference, meaning the cancer surgery is the same, the incontinence is about the same, and also the preservation of erectile function is the same. All right. Then the last thing I'm going to talk about is robotic prostatectomy, what to expect long term. All right, so here it is. So after a radical prostatectomy, most patients will have a catheter in for 1 or 2 weeks. After the catheter is removed, most patients will have some form of incontinence. Some people have incontinence for a few hours, a few days. Some patients will take, weeks or months to regain their control of urine. The reason for that is dependent on the patient, dependent on the type of cancer they have, how big their prostate is, and what type of urinary symptoms they have before the surgery. If patients already have some incontinence or problems urinating, or they have a big prostate, or they have a large amount of cancer that requires a larger amount of debulking of the tumor, they may take longer to recover. In addition, we know that older gentlemen will take longer to recover from the surgery. Patients who've had multiple medical comorbidities may take a little longer to recover. But in the end, I think the vast majority of my patients, over 97 to 98% of my patients, after 6 months to a year, will regain their control of urine and not have to worry about long-term incontinence. Now, my definition of incontinence is not 1 or 2 pads a day. My definition of incontinence is 0 pads a day, meaning the vast majority of my patients, over 97, 98% of my patients over the last 19, 20 years of performing the surgery will not require a daily pad or diaper, as they will regain their control of urine. Next portion will be, I'll talk about the sexual dysfunction. A lot of patients are worried about preservation of their erectile function after the surgery. As I've talked to you before, in removing the prostate, which is a sexual organ, once you remove the prostate, there will no longer be any ejaculation or ejaculatory products such as semen. However, in patients that have good erectile function, and I'm able to preserve their nerves, their neurovascular bundles, nerves that are important for preservation of erections, those patients can still maintain their erectile function. Again, it all depends on the patient's pre-surgical condition. If you have poor erectile function, likely after the surgery, your erection will not be any better. But if you have good erectile function, and I am able to preserve your nerves, then you're most likely be able to regain your erectile function and still be able to perform sexual activity. I encourage that all my patients, before and after surgery, if they are interested in preserving their erectile function, be very attentive and very proactive in doing what's called penile rehabilitation, which is to try to engage into getting maintaining and obtaining and maintaining erection every day, or at least 3 or 4 times a week. There's a use of oral medications such as tadalafil or sildenafil, which are the generic Cialis or Viagra, to help with maintaining blood flow to the penis. In addition, there's use of the vacuum erection device. It's a cylindrical device that can be operated by manually or battery operated, to put on the penis to pump up and bring a vacuum state to bring blood to the penis to maintain an erection. And then finally, there's the option of what we call intracorporeal injection, where you will deliver the medicine directly into the penis to help bring the erections after surgery or before surgery. Now, the degree of which you are able to regain your sexual function, your erections, is dependent on your age, your comorbidity, the status of your erection before the surgery, as well as your cancer status and how much nerve preservation can be performed. The vast majority of the time, I try to preserve the nerves as much as I can using what we call a thermal technique during the surgery, where I'm very careful about delicately teasing the neurovascular bundles off the prostate. The neurovascular bundles are located on the bottom, or 5 and 7 o'clock position of the prostate, going up towards the 11 and 1 o'clock position. So I would peel the nerves off and just take the prostate out, and try not to do a lot of traumatic movement or dissection that can cause damage to the nerves, or even and avoid any type of cautery or heat, or I try to do what's called an athermal technique to try to preserve nerves so that the erections can be preserved. Okay, so I'm going to go back to the urinary incontinence. So some of the things that help with the patients in preserving or regaining their urinary incontinence is to perform pelvic floor exercises, or what we call the Kegel exercises, prior to and after the surgery. Of course, you wouldn't want to be doing these exercises while you have the Foley catheter in, but definitely sometime after the surgery. We like to start it sooner than later, and definitely some people may benefit from having the Kegel exercises and the pelvic floor exercises to be performed prior to the surgery, and thus they can get an idea of how to do these pelvic exercises, strengthen up the muscles of the pelvic floor to help with the control of urine. Again, these exercises, some people have the thought that if they do 1,000 of these a day, they would have better continence. The answer to that is that you shouldn't overdo those exercises. If you overdo the exercises or you do it incorrectly, you can actually cause more damage, such as worsening incontinence or even pelvic pain. Recommendation is maybe a set of 10 of these pelvic floor exercises once, twice, or 3 times a day. So not a whole lot, not hundreds or thousands, but maybe a few dozen. That's what I would recommend. And we usually, like I said, we usually see incontinence resolve for some people, if within a few days after the catheter has been removed, some people a few weeks, and others may take a few months. The best thing is to continue to do the exercises and give yourself a little bit of time and patience, because your body has to heal up from the surgery. And we know that typically after a major surgery like this, most patients won't heal up completely until about 4 to 6 weeks. So sometimes it takes about that long for both the body to heal up, the incontinence to resolve, and maybe for the erections to come back.